systemic disorder of AL amyloidosis. I want to invite Jenny Pinney, consultant nephrologist from Queen Elizabeth Hospital in Birmingham. Jenny was also awarded an MD from UCL in amyloidosis. Jenny recently chaired the writing committee for MGRS VSH best practice guidelines, and she also chairs the MGRS rare renal disease group. Jenny, over to you.
Thank you very much for the invite. So I don't have any disclosures, but again, my main disclosure is, as you've heard, I'm not a haematologist. So I'm coming at things from a slightly different perspective. And was given the remit of talking about AL amyloidosis and MGRS. And when I was thinking about what I was going to talk about, I effectively thought, well, actually, is there much of an update in AL amyloidosis in kidneys, aside from what we've already heard around treatment options and the cardiac aspects? And probably isn't vast amounts to talk about from that aspect. But there's quite a lot going on in the MGRS world and within renal aside from that. So I've slightly gone off on a tangent and thought about from this last 12 months and where are we at and what is that kind of up-to-date update for us. So there's three big papers really, I think, that have come out this year. And that's what I'm going to focus on. So the MGRS best practice paper, there's a histology update paper, and there's a renal transplantation in plasma cell dyscrasias and myeloma paper that has literally just come out, which I think is, certainly from the nephrology world, quite exciting, and want to really put that out there. So earlier this year, we presented this VSH guideline, which was the diagnosis and management of MGRS. And you can now find that on the website, and you can find the podcast on the website. Not that I'm particularly advertising that. Essentially, that was that guideline committee. That was a lot of people coming together for quite a long period of time to put together a very long best practice guideline. And within that guideline is many appendices about describing all of the different MGRS lesions. So if you want to know more information about individual topics, that's all within there. But the key aspects of that is really how to diagnose patients and what we should be doing in terms of treatment. So the key messages from that paper really is thinking about MGRS and screening for MGRS and making the diagnosis in the first place. And if patients have an MGUS and they're presenting into a haematology clinic, what should we be doing at that first visit in thinking about diagnosing and picking up MGRS and within that amyloidosis? And when we think about kidneys and kidney assessments, we think about the kidney function and we think about what's in the urine. Within the kidney function aspects, we do an EGFR, and the EGFR EPI is the best practice guidance from a nephrological perspective for the calculator that we should be using to then describe chronic kidney disease. Creatinine is still used and is effectively, there are differences and there are things coming through in terms of optimal measures, but effectively in most hospitals we're still using creatinine. Urinalysis is important, and doing a urine dipstick means that you know whether there's both blood and protein on a urine dip. And why is that important? If you've got just protein on a urine dip, then what's likely to be going on is more potentially nephrotic syndrome, but less likely to be something where there's damage happening inside the kidneys. If you've got blood and protein on a urine dipstick, then the severity of what's going on in someone's kidneys is more likely to be potentially worse, and the threshold from which we would consider a kidney biopsy is different. So that urine dipstick is important at that first and early stage. And then the ACR is important. And the reason why that's important rather than a PCR, the protein creatinine ratio, is because an ACR picks up glomerular proteinuria. If you've got someone who's got an MGUS and they've got light chain, or that light chain's significant and it's going through into the urine, you will find an abnormality on the PCR because you're picking up the light chain protein, whereas if you're doing an ACR, you will then be picking up glomerular proteinuria, and that's where that difference fits effectively. And who does a nephrologist want to see? Who are we going to consider kidney biopsy for, and where's the kidney disease? Well, effectively, if you've got an ACR of more than 30 and an MGUS, we would have a lower threshold for biopsying those patients. And if we've got changing kidney function, so if you've got somebody who's had the same kidney function for the last 10 years, then we're less likely to biopsy that person than someone that's got a dynamic change and we can see progression. If we're on the other side of this coin and we're going in the nephrology clinic, then pretty much every patient that comes through to a nephrologist will have that initial screen and will get screening for myeloma as part of those initial tests that we do, alongside anchors and various immunological tests that we do. And we should be biopsying patients who we're concerned have an MGRS. And the paper from Jason that was published in 2020 showed that we're more likely to get an MGRS lesion on a kidney biopsy if the ACR is more than 100, if there's microscopic hematuria, and if you've got an abnormal serum free light chain ratio. So who should we be then considering treatment for, and what should we then be doing? If we've had a kidney biopsy and there's potential there for an MGRS lesion and the histopathologist is saying, I think this could be MGRS, this patient's got an abnormal clone and the two are marrying together, then those patients warrant full workup in terms of imaging and a bone marrow biopsy. And it's not an uncommon scenario to have the kidney consultant kind of then saying, okay, we've done all of these things, we've done this test, and the haematologist has come back to me and said, well, they've just got an MGUS, I don't want to treat this patient, I'm not interested. Why is that important to kind of try and get away from? Because we're expecting it's going to be an MGUS, and you're doing these investigations almost to enable you to have greater ease at getting that diagnosis through and greater ease at delivering the chemotherapy, but the expectation is you're going to find it's an MGUS and that you're going to find that there isn't any other end organ damage aside from the kidney disease, but we still want to treat these patients. And the reason why we want to treat these patients is because people with kidney disease do badly. Survival on dialysis is very poor, and as we age, our survival gets worse. If you go on to dialysis at the age of 20, your prognosis on dialysis is only about 20 years. If you go on to dialysis at the age of 70, your prognosis on dialysis is about 5 years. We know that kidney patients have a worse prognosis than most people with cancer, so we need to try to prevent end-stage kidney disease. And most of the conditions that we have in the world of nephrology have mitigations, and we have ACE inhibitors and we have SGLT2s, but we don't often have treatments that can reverse, improve and make people better. But you do, and so that's why we're so keen on trying to treat these patients. We know that what we want to do is try and minimize toxicity, and clearly with chemotherapy comes toxicity, but at the same time the principles of the treatments is to try to achieve the best hematological response possible whilst minimizing that toxicity and targeting the precursor protein that's causing the damage to the kidneys. We know that in this study of 100 patients, it's small numbers, it's not huge studies, and these are rare diseases, but those patients who achieve at least a VGPR have a better prognosis. And if we delay those treatments and allow those patients to start to progress towards end-stage renal failure, then again, they do worse. And it's important to remember that chronic kidney disease is an independent risk factor for cardiovascular disease. And as your kidney function declines and gets worse, moving through into chronic kidney disease stages 4 and 5, so GFRs towards below 30, that again, your immune system stops working, you're more likely to develop infections, you're more likely to get viruses and do worse from them. During the COVID pandemic, during the seasonal flu, our patients do particularly badly because their immune systems don't work. And if we've got the ability to halt that disease and prevent that progression, that's what we want to be trying to achieve. So the key recommendations really in terms of the treatment aspect of this best practice paper is that we want to define the treatment according to the underlying clonal disorder because you're targeting the problem at source. You want to try to prevent kidney damage and progression to end-stage renal failure. And so for patients who have already reached end-stage renal failure or are very, very close to it, then your treatment may be too toxic for that patient and it may not prevent them from getting worse. But we want to treat patients early and we want to prevent that. We should be thinking about this through a specialist MDT because these decisions are quite difficult. The nuances around histopathology is tricky, and actually having that time together where you can put your heads together between haematology, histopathology and nephrology to do the right thing for this patient and understand where the goals are for that person, how frail they are, how fragile they are is really important. And also having the patient in the centre of that MDT and having someone in the MDT who's met the patient is also absolutely key, because sometimes we make decisions about people on paper when actually they could have cartwheeled into the room or they've dragged themselves into the room, and that's very different for different people. What we want to then consider is those people who have already progressed to end-stage kidney disease, and if they're potentially eligible for a kidney transplant, which we'll go on to in a minute, then again, you do want to treat these patients because that's, again, a different ballpark, and you may then improve that patient's survival significantly. But you want to try to get the deepest clonal response possible. And in some patients, that may mean a stem cell transplant. And especially if you're wanting to transplant somebody, you want to try and get them into CR if at all possible. So moving on to the second big paper that came out in terms of the world of MDRS this year, it's this one, and this was published in the summer in Kidney International. So this was a meeting report after, as part of the IKMG, the International Kidney Myeloma Working Group, put together a consensus criteria for histopathological changes. And so I won't necessarily go through that because I think this is much more of a histopathology paper, but at the same time, there are key highlights within this for the tests that should be happening for diagnosing MDRS, but also making sure that we've got consensus really for the histopathologists and going back to them to say, okay, if there's a query on whether this might or might not be an MDRS lesion, utilising these the tables within this paper to help. And it's important to remember that not all kidney biopsies and reports are the same. There is a variety of different tests and measures that may or may not have been done on that kidney biopsy. And all kidney biopsies effectively have a Congo red stain on them. And we often find that there are false positives and false negatives with that. So it's important to remember that if your patient isn't quite fitting with the diagnosis you've got, you may well want to question that diagnosis and certainly get a second opinion. So send that sample down to the NAC if you think actually this patient has not been reported as amyloid and we really, really think that there's something on there. You might want that second opinion, and vice versa if it's just not fitting. Immunohistochemistry is done in most places in the UK, but immunofluorescence is best practice, and in America and Europe they effectively only use immunofluorescence, and it's now starting to come. There are multiple areas within the UK that do use immunofluorescence, but not all units. And so if there's a query and you're not sure, then linking in your histopathologist with a histopathologist that does immunofluorescence can be very helpful, and ensuring that patients have had electron microscopy. Again, that's not offered in all labs, and some places have to send their samples off to other labs around the country to do the EM, but you can't make a diagnosis of light chain deposition disease, for example, without EM. So it's really important that your sample is sent for that. If there's fibrils on the biopsy, then a DNA JB9 is important, and that can be done in a couple of units in the country. And then thinking about if your diagnosis fits with a couple of key diagnoses, but it's not looking like it's an MDRS and you're not getting the immunofluorescence light up, then actually doing pronase digestion to enhance that light up is important, and they do that down at the Hammersmith. So this is the paper that I've been waiting for, certainly, and I think the nephrology world has been waiting for quite a while, and really knowing what to do about kidney transplantation in patients with myeloma and plasma cell dyscrasias. And this paper is again a meeting report published in Kidney International, which came out online last month and is now coming out this month, effectively is a really good paper. So it describes specific cases, and from those cases gives then best practice guidance on what to do and whether these patients are potential kidney transplant recipients. So apologies if I say the word transplant, I mean kidney transplant as opposed to stem cell transplant. And historically, myeloma patients haven't had kidney transplants particularly. When we think about solid organ malignancies, often we wait to make sure, for a variety of years, to make sure that their person is not going to die from their cancer. And there's whole charts as to how long people need to wait for various different cancers to be able to go onto the kidney transplant waiting list. And myeloma has been one of those things where maybe a few years ago people would have said, oh, well, maybe if we wait 5 years and they're kind of okay, then maybe they could have a kidney transplant. But there really wasn't anything out there. And as you know, that the prognosis for myeloma is now massively different from where it was a few years ago. There is many more treatment options for patients, but waiting for a patient, you're waiting for them to relapse effectively, and there is no point in doing that. So it's changing that mindset of nephrologists and haematologists in terms of thinking about not waiting, getting them a kidney transplant early, opening the doors to potential future options for treatments for patients. It's really important to remember that if patients with plasma cell dyscrasias have progressed to end-stage renal failure from either amyloid or an MDRS and they're not treated, that disease will recur in their kidney transplant, and it will recur at varieties of speeds post-transplant. So if they've got uncontrolled cast nephropathy and you put a kidney transplant into them, then they will immediately get cast nephropathy. Light chain proximal tubulopathy, C3, PGNMID, these all kind of recur within about 6 months of a kidney transplant. And then the light chain deposition disease, immunotactoid a little bit later on, and AL a little bit later down the line. So it's absolutely key that these patients are in a complete or at least a VGPR in order to even consider a kidney transplant for them. And so I guess my nod to the AL amyloidosis bit would be that certainly for patients who have AL amyloidosis, who have isolated kidney disease and they've been treated and they're in CR, then they're absolutely potentially entitled to a kidney transplant if they would otherwise be suitable for a kidney transplant. So if they are going to live for more than 5 years, which is the fundamental for whether or not we would offer a kidney transplant to a patient, if they are going to get through that operation from a cardiovascular perspective, then we would want to offer them a kidney transplant. If people have got AL amyloidosis and they have not just got it in their kidneys, but they've got cardiac involvement, autonomic dysfunction, if they're frail, if they've got GI tract involvement, then you may not want to offer those patients a kidney transplant. And absolutely that decision needs to be taken with experts in an MDT setting with that patient. And so, but thinking about it and asking the question is probably where we want to be. So what about the multiple myeloma patients? What's the recommendations for these people in terms of having a kidney transplant? Well, essentially, what they've done is, I think this is a nice kind of way of thinking through things from the paper. So they've just directly picked this up from the paper. It's thinking about the risk of relapse. So if you've got a patient who is standard risk of relapse, so no high-risk cytogenetics, no extramedullary disease, and they're in the group 1 aspect, and they are MRD negative, then they say, yep, go ahead and offer this patient a kidney transplant. You don't necessarily need to wait. If you are standard risk, but you're not MRD negative, then, but you're in a CR or at least a VGPR, then you may want to offer this patient a kidney transplant, but you're going to need to wait a little bit in terms of 12 months for this patient to become transplant eligible, to just be sure that they're effectively steady. So in order to get onto the transplant waiting list, you do need to fully reassess that patient. They're going to need another bone marrow biopsy whilst as part of the listing process for a kidney transplant. If somebody is then high risk for relapse, but MRD negative, then their recommendation is that you wait a little bit longer, so between 1 and 2 years, and then consider it. And if somebody's very high risk, they're not MRD, they're MRD positive, and they're a high risk of relapse, then you're not going to offer that patient a kidney transplant. And we really want to be thinking about this in the early stages of somebody's disease. We, in Birmingham, wrote a kind of protocol about 18 months ago for who we thought we were going to transplant, and then was very heartened that most of this was there because there was just nothing in the literature. And so actually what we were then doing was saying, well, in order to get the longest response, I think these patients should have a stem cell transplant. And we've had a patient who we put through a stem cell transplant who was in CR, and then fundamentally after that had been on dialysis for about 18 months, came off dialysis, no longer needed the kidney transplant because his kidney function got better. So it was all marvellous. But it did make me reflect on the fact that in this paper and the kind of grouping of best practice, they haven't said people have to have a stem cell transplant in order to get a kidney transplant. And so that was something new in my mind, and that's something that we will change in terms of our protocol. And part of the reasoning behind that is actually the patients who have had a stem cell transplant or CAR T therapy before a kidney transplant have had a higher association of infections and secondary myeloid and non-myeloid malignancies. So they want people clearly to be in a CR, but it doesn't have to be that you're then putting them through a stem cell transplant in order to have that kidney transplant. And it may be that we can transplant them after the kidney transplant and the other way around. When thinking about the actual transplant itself, promoting live donor transplantation is absolutely key. The thing about transplantation essentially is if you've got a live donor, you can time it. You know when you're going to bring that patient in, you've worked up the person, and if they're on maintenance chemotherapy, you can pause it, you can stop it, and you can reduce and mitigate that risk. If somebody's on the deceased donor kidney transplant waiting list, you don't know when they're going to be called up for a kidney transplant, so you can't stop your therapy in advance and reduce that risk. So we really want to be pushing people really for live donors if at all possible, but we're not going to preclude people from going on to the deceased donor waiting list. But it is important to always remember that when you're transplanting one person from the deceased donor waiting list, you're not transplanting somebody else. And so if you're really thinking about somebody who's had several lines of therapy and are later down the line, you have to consider whether they're truly going to benefit from this transplant. And that's where kind of treating early and doing this in the early part of their journey is important. We know that IMiDs, so lenalidomide, are associated with a higher risk of rejection, and there is a thrombotic risk around that. So at the time of putting a kidney into somebody, there is a chance that that kidney could clot off, and if they're on lenalidomide, then there is a concern around that. Because of the half-life being very short, certainly in our own hospital protocol, we've effectively said, okay, we will enhance enoxaparin for about 48 hours around the time of the operation. Clearly immediately stop the lenalidomide if somebody gets called in. But the recommendation is to stop if you are having a live donor transplant 4 weeks before the operation. And if somebody's on DARA or Velcade, then 2 weeks before the operation. What about those patients with an MGUS? So this is not the MGRS patients. If you've got an MGRS patient who's progressed to end-stage renal failure and you're going to put them on the kidney transplant waiting list, then they have to, again, as we've said, have had treatment and be in at least a VGPR, if not a CR. But if you've got a patient as part of that screening that hasn't got an MGRS, but they are on the kidney transplant waiting list, and they have been found to have an incidental MGUS, then they need the full investigations to make sure that is just an MGUS. They're going to need bone marrow and they're going to need imaging. And if it is just an MGUS, then there is nothing stopping them from going onto the transplant waiting list. But again, it's about the risk of that progression and the risk of a patient needing treatment in the future. And so effectively, what they've done in this figure is think about that risk. So if somebody's got smouldering myeloma and they've intermediate risk, so they've got 2 of the risk factors on the right-hand side there. So they've either got a paraprotein of more than 2, a light chain ratio of more than 20, more than 20% plasma cells, or high-risk cytogenetics. If they've got 3 to 4 of those risk factors, then the recommendation is to treat that patient in advance of listing them for a kidney transplant. If they're in the intermediate risk or they're just an MGUS, then no recommendations around treatment before putting them onto the kidney transplant waiting list. So to summarise, I think the key bits really from my perspective is if you've got a patient with an MGRS, please treat them. Please treat them early, and please don't just say, oh, they've just got an MGUS, we're not worried, because it does matter for the patients. It is important for these people because you can do something about it. And from a transplant perspective, I think we're now going to enter into a newer world where kidney transplantation is much more on the agenda for these patients. And hopefully this is going to be good for our patients, because we know that effectively having a kidney transplant in most people usually doubles their life expectancy as opposed to being on dialysis. And I think we're taking questions at the end, aren't we?
Thank you very much, and we'll take questions at the end. So they're not quite sure how the next session